Extrapleural pneumonectomy, which is generally referred to as EPP, was once considered the gold standard surgery for pleural mesothelioma. When performing EPP, surgeons removed the entire lung, the pleura, the diaphragm, and pericardium in an attempt to eliminate all visible disease. But research, particularly the MARS-2 trial that was published in 2022, showed that EPP doesn't improve survival and often worsens quality of life compared to chemotherapy alone or less radical surgery. Today, I want to explain what it involves, why it was performed for decades, what research revealed about its outcomes, and why most mesothelioma specialists have moved away from this approach. I'm Terry Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician, and this is not medical advice. But understanding the evolution of mesothelioma surgery helps you evaluate treatment recommendations and understand why EPP is rarely performed today. Let's start with what extrapleural pneumonectomy actually involves. EPP is one of the most radical operations in all of thoracic surgery. The surgeon removes the entire affected lung, all the pleura on that side, both parietal pleura lining the chest and visceral pleura covering the lung, the entire hemidiaphragm, which is the half of the diaphragm on the affected side, and the pericardium, which is the sac surrounding the heart on that side. After removing these structures, the surgeon reconstructs the diaphragm and pericardium using synthetic patches, typically Gore-Tex or similar material. Patients undergoing this were left with one functioning lung, a reconstructed diaphragm, and a reconstructed pericardial sac. The operation takes 10 to 6 hours and recovery is extremely difficult. The rationale behind it was that mesothelioma spreads across the pleural surfaces and invades into the lung. Removing the entire lung, along with all pleura, theoretically removes more disease than lung-sparing procedures that try to preserve the lung. So the hope was that this aggressive approach would improve survival. From the 1980s through the 2000s, EPP was performed at many major centers and was considered by many surgeons to be the most definitive operation for resectable mesothelioma. Now, I have a lot to cover on this, and before I go on with the history, I want to take a break here and ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us, like you did. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end because I'm going to give you valuable information on where to find resources that will make a real difference for you. Back to EPP. There were several problems with the surgery that became increasingly apparent. First and most obvious was operative mortality, which means death during or shortly after the surgery. For EPP, the operative mortality rate was high. Even at the best centers, 5 to 7% of patients didn't make it through the operation or the immediate postoperative period. At less experienced centers, mortality reached 10 to 15% or higher. The second problem was that morbidity, which means serious complications, was also extremely high. Patients frequently experienced cardiac arrhythmias, respiratory failure, infection, bleeding, and other life-threatening complications. Many spent weeks in the hospital recovering from the surgery and from complications. Third, the quality of life after EPP was often poor. Living with one lung significantly limits exercise capacity and daily function. Some patients never regained a good quality of life even if they survived the immediate postoperative period. Fourth, and most importantly, the survival benefit was questionable. While some individual centers reported encouraging results with median survivals of 16 to 20 months or more in carefully selected patients, these were highly selected patient populations and not representative of the norm. When broader groups of patients were studied, outcomes were a lot less impressive. There were no randomized trials conducted to compare EPP to other treatments, so it was impossible to know if the surgery actually helped or if good outcomes just reflected careful patient selection. Now, this brings us to the MARS 2 trial, which was published in 2022 in the highly respected medical journal, The Lancet Oncology. MARS 2 was a randomized controlled trial conducted in the United Kingdom. Randomized control trials are considered the gold standard of medical research. Patients with resectable pleural mesothelioma were randomly assigned to either receive chemotherapy alone or chemotherapy followed by the EPP surgery. The study's design allowed direct comparison of outcomes, and the results were sobering because they showed that EPP provided no survival benefit. In fact, the median survival was actually slightly worse in the surgery group, 14.4 months with EPP versus 16.1 months with chemotherapy alone. The difference wasn't statistically significant, but surgery certainly didn't help, and it might have hurt. Quality of life was definitively worse in the EPP group. Patients who had the surgery experienced more complications, longer hospitalizations, worse physical function during recovery, and an overall poorer quality of life in the year following treatment. Operative mortality was 5% despite the surgery being performed at experienced centers in the UK, with 1 in 20 patients dying from the operation. The trial's conclusion was clear. EPP should not be a routine treatment for malignant pleural mesothelioma. Patients lived just as long or longer with chemotherapy alone and had a much better quality of life. How did the mesothelioma community respond? Many specialists had already been moving away from EPP toward lung-sparing pleurectomy decortication based on earlier data suggesting that PD had similar or better outcomes with lower mortality and better quality of life. And MARS 2 accelerated this shift. Most major centers in the United States and Europe have either stopped performing EPP entirely or they perform it very rarely in exceptional cases. Current guidelines from organizations like the National Comprehensive Cancer Network reflect the evidence. EPP is not recommended as routine treatment. Instead, PD is the preferred surgical approach if surgery is performed at all. Are there any situations where EPP might still be considered? A very small number of surgeons still perform EPP in highly selected cases, typically young patients with very early stage disease, excellent lung function so they can tolerate living with one lung, epithelioid cell type with favorable features, and strong patient preference for the most aggressive approach despite the risks. But these cases are now rare. Most patients previously considered for EPP are now offered PD or chemotherapy without surgery. What if you're at a center where EPP is still being recommended? This should raise some questions. Ask your surgeon whether they're aware of the MARS 2 trial results and why they still recommend EPP given this evidence. Ask how many EPP operations they perform and what their outcomes are. And ask what would be the alternative. PD or chemotherapy without surgery? Consider getting a second opinion at a center that has adapted evidence-based practices and moved away from EPP. Here's another important question to consider. What does this evolution in mesothelioma surgery teach us? It teaches us that medical practice should be based on rigorous evidence, not tradition or a theoretical rationale. Just because an operation is technically feasible doesn't mean it should be performed. Quality of life matters as much as survival duration. An operation that extends survival by a few months while causing severe complications and poor quality of life, it might not be worthwhile. Randomized trials are essential for establishing which treatments actually work. Lung-sparing approaches can achieve similar outcomes to lung-removing approaches with less morbidity and better quality of life. The story of EPP is also a reminder to question aggressive treatments and demand evidence of their benefit. Some patients underwent EPP at significant personal cost. They suffered operative deaths, terrible complications, or prolonged recoveries, and the procedure ultimately didn't improve their survival. If you or a family member underwent EPP in the past, this isn't about assigning blame. The surgery was performed in good faith based on the best understanding at the time, but we now have better evidence guiding current practice. To review, extrapleural pneumonectomy, or EPP, removes the entire lung, pleura, diaphragm, and pericardium in a 6 to 10 hour operation with 5 to 7% operative mortality and high complication rates. The MARS-2 trial conducted in 2022 showed that EPP provides no survival benefit versus chemotherapy alone and significantly worsens quality of life. Most mesothelioma specialists have stopped performing EPP except in rare, exceptional cases. Instead, the current preference is lung-sparing pleurectomy decortication or chemotherapy without surgery. If EPP is recommended to you, question why, given the current evidence, and seek a second opinion at centers that follow evidence-based guidelines. You can visit mesothelioma.net for current information about mesothelioma surgery options, or call 1-800-692-8608 or use the live chat feature on our website to speak to one of our patient advocates immediately. As for me, remember to post your questions below, and I'll see you next time.